Well, good day to you. In this lesson, we're going to talk about patients with chronic kidney disease. And as you can see in that picture there, that's a patient who has end-stage kidney disease because his chronic disease had advanced so much he ended up on dialysis. We're first going to begin our lesson today by taking a few pre-assessment questions, and as we typically have done, please pause the slide so you can read the question, because I am going to, in a moment or two, just click forward after the slide appears. Here's your first question. Please pause. And here is our answer. I'll let you pause again if you would like to read the rationales. If not, I'm advancing forward. Next question. Please pause. And here's our answer. I am not sure if you knew about it or not, but the creatinine is actually more sensitive than the blood urea nitrogen level. The reason being is because, let me get my highlighter here, just gotta click, and let's do yellow. A few things will actually impact our BUN if we even had healthy kidneys, and that is high protein diets. Wow, you can't even see that. Green? Nope. Okay. So much for a black slide, huh? High protein diets, rapid protein catabolism, such as in a state where somebody is excessively exercising or excessively, breaking muscle down, say they're in a state of starvation. And also dehydration. These will actually cause an elevated BUN. And so because there's a couple different reasons that will elevate our BUN, we can't say it's the best indication of our client's renal status. It's good, but creatinine's better. How about that? Ooh, here is our last question. You're definitely gonna have to pause for this. Yes, I brought back all of those different acid-base problems that we took a long time ago. So hopefully your answer was A. In fact, if I had to ask which one of these is compensated, well, let me back it up. The answer is A, because kidney patients oftentimes have problems with metabolic acidosis. Metabolic acidosis. Now, looking at these numbers again, which of these are a compensated blood gas? Pause. Okay, the answer is B. B is a compensated example of a blood gas. Particularly, B is compensated respiratory acidosis. Great. Now, which of these are uncompensated blood gases? Well, let me rephrase that. Which of these is an uncompensated arterial blood gas? As I pause again, the answer is D. D is uncompensated metabolic alkalosis. And that is because only one of the values are abnormal. Not talking about the pH, the other two. One of them is normal and one is abnormal. Okay, and then what does that make the others? That makes the others, such as A and C, as partially compensated blood gas. In fact, A is partially compensated metabolic acidosis and C is partially compensated respiratory alkalosis. Well, let's begin. Well, what is chronic kidney disease? That's a great question. Well, it is a progressive, irreversible kidney injury which after some time, we notice that the kidney function does not recover, and specifically, it is after 3 months of poor kidney function. Chronic kidney disease, it may be asymptomatic for the most part, except during periods of stress. We mean physical stress, such as infection, surgery, and even trauma. Clinical manifestations become apparent the longer the kidney dysfunction progresses. So as we move through the different stages of kidney failure, you won't see much, but then over time, the longer the patient has kidney failure, the more years they have kidney failure, we're going to actually see more of those symptoms that are listed in that very large table in your book. Now, older adults are at an increased risk for chronic kidney disease. Well, chronic kidney disease and lower kidney function, that's kind of part of the normal aging process, but they don't all have chronic kidney disease. They may have, say, stage 1 or stage 2 or maybe even stage 3 kidney disease as they age, because kidneys do not filter as well as younger kidneys. Some other reasons why older adults are more prone to chronic kidney disease is because they may be less mobile, possibly on bed rest. They may possibly have altered mental status. Not all of them, but as we age, we do develop dementia. Their sense of thirst is decreased, leading to higher chances of dehydration. And oftentimes they have mobility issues, so they do not have easy access to water. A little terminology here, azotemia. This is the buildup of nitrogenous waste in the blood. Diagnostic indexes are commonly used to differentiate between the different types of azotemia. Maybe it's intrarenal azotemia or postrenal azotemia, meaning why do we have a high buildup of nitrogenous waste? That's a little bit more advanced. We just need to know that if we have high BUN, they call that azotemia. And there are no clinical manifestations, you just see that on the blood work. Now, if our patient has azotemia or high BUN with clinical manifestations, we call this uremia. Now, if we have a high BUN, clinical manifestations, and fluid and electrolyte imbalances, yes, I did use Gatorade to be my exemplar picture. If we have all of 3 of these together, we call this uremic syndrome. Uremic syndrome. That's when we have high BUN, clinical manifestations, and fluid and electrolyte imbalances, and hormone imbalances. Now, if we have all of these things and we have to have dialysis to live or a kidney transplant, then we have now progressed to end-stage kidney disease. So those are the terms I'm going to try to be using today, or if I don't use them, at least you know them now. And no, those are not real size. That's not the real size of kidneys. They are just kidney beans. Okay. First thing we need to know is the stages of chronic kidney disease, because not all kidney disease patients are the exact same, and it really differs what we're going to do, how we're going to treat the patient, what medications they're going to be on, according to the stage of kidney disease that they are in. So staging is extremely important when it comes to kidney disease. First thing we need to do is look at a patient's GFR. GFR is glomerular filtration rate. This is an estimation of someone's filtration rate based off their blood work. The rate of how we filter urine cannot exactly be directly calculated. Well, how do we get this number then? That's a great question. They use an algorithm in the background which calculates a patient's serum creatinine, their gender, their age, their weight, and race to make an estimated GFR. Well, I encourage you to look up your patient's GFR in the hospital, and when you do so and you open the little notes section in the lab results, you'll notice that they have a disclaimer about how providers should interpret the automatic GFR with caution, because it is just an algorithm in the background. In most people, the GFR is 90 or greater in healthy individuals. Now, in the elderly and the infants, the GFR will be about 60 to 89 milliliters per minute. But they do not have any other signs or symptoms of kidney disease, and then creatinine is within normal limits, so that's okay. We're actually okay with that. Now, let's just say if their GFR is 60 to 89, but they have proteinuria, protein in the urine, for 3+ months or more, now we say that they are going to have early kidney disease. So if their GFR is about 60 to 89 and they have proteinuria for about 3+ months or more, then that's when we say they have early kidney disease. Now, if their GFR is less than 60, if it's less than 60 for 3 months or more, the patient definitely has chronic kidney disease. Less than 60 is not normal. End-stage kidney disease exists when about 90%, that's down there, stage 5, end-stage kidney disease, exists when about 90% of the functioning nephrons have been destroyed and they are no longer able to maintain fluid, electrolyte, and acid-base homeostasis. And usually in stage 5 kidney disease, that's whenever people don't urinate anymore. In fact, they will be dependent upon dialysis or peritoneal dialysis to sustain life. Some urinate, some don't. If you ask them, when was the last time you peed, they'll be like, last week. That's pretty infrequent. We're going to begin by talking about some of the changes that occur when somebody begins to develop chronic kidney disease. Well, inside the kidneys, we're going to have more and more nephrons lose their ability to produce urine. Now, with that is going to come disruptions of our fluid, our electrolytes, and our metabolic system. So let's first look at some of the metabolic changes. The first thing we're going to see is an increase in urea. Urea is a protein metabolism byproduct, and how we can measure if our kidneys are good or bad is oftentimes of how high our urea is. But do know that urea is directly related to dietary protein intake. So somebody could actually make their BUN go up if they had large ingestion of protein. That's why it's a little less reliable when we're looking at the kidneys. Our creatinine, on the other hand, is a better way to measure if our kidneys are doing good or not, because creatinine inside our body is actually a protein byproduct that is made from our skeletal muscles, and the rate of excretion, although it may depend on muscle mass and physical activity and a little bit of diet, is going to let us know how our kidneys are doing. So we are going to check our kidneys, and according to how much creatinine they're excreting, that's how we know if they are good or bad. We're always excreting creatinine all day, every day. But okay, looking at our electrolytes. Now, this is a little challenging for students, but I'll try to do my best in breaking this down. In early kidney disease, we are going to see a low sodium, so a sodium less than 135. In late kidney disease, we're going to see an elevated sodium, greater than 145. And that's because in late, I guess I should describe that. In late kidney disease, the kidneys are unable to excrete, they're not able to produce urine, and sodium is going to be retained, and this is going to cause hypertension and some fluid imbalances. And in early kidney disease, our sodium is going to drop because the kidneys cannot reabsorb the sodium as well. So they're going to be peeing out all their sodium, and we're going to have polyuria. Usually, low sodium is going to be obvious in mild to moderate kidney disease. Now, I bet you're wondering, what is FVE? That is fluid volume excess. So there are particular situations when our sodium is going to drop. If we are in late kidney disease, we are doing our thing, we have advanced kidney disease, but we consumed too much water. Well, our sodium in that instance, if our kidneys aren't working and we're not peeing, our sodium is going to be falsely diluted down. So if I were to draw your blood work and you had advanced kidney disease and you had fluid volume excess in that moment, you're going to have low sodium. And I'm going to say, wait, I thought you had late kidney disease. And we're going to say correct. However, your fluid volume is so much, it's actually diluting out your sodium. Well, how am I supposed to know? Because I thought low sodium was supposed to be an early kidney disease. Well, good question. To really figure out when somebody's sodium is low and if it's falsely, low because it's diluted, you need to check their osmolarity. When you check their serum osmolarity, and if it's showing low, like less than 280, that's how I'm going to know, you have tons of fluid on you. And if I were to say diurese you, I might get a better picture of your actual sodium status. That's a hard one to grab. I hope I explained that okay. Okay, in chronic kidney disease, our potassium is going to be elevated. Now, it's going to remain normal for the most part until somebody's urine output starts dropping below 500 mils a day. So early kidney disease, their potassium won't really change, but as we move on through that continuum and they stop peeing, or they pee very little, like less than 500 mLs a day, that's when we see their potassium go up. And as you'll notice, magnesium really likes to follow potassium. So when somebody's potassium is up, their magnesium oftentimes will rise as well. They're buddies. Let's see. Okay. Metabolic acidosis. All right. So this can occur usually in later kidney disease, but it can occur at any time. This is because our serum bicarbonate is going to be greater than 26. I think I said that wrong. 22 to 26. No, dang it. It's going to be, their serum bicarbonate is going to start dropping. It's going to be less than 22. I know, don't hate me. So the correction of metabolic acidosis can usually be taken care of quite easily. I'm going to show you some interventions that we're going to do. And it will improve somebody's functional status quite well. Okay, the whole calcium and phosphorus dilemma. Boy. So what happens here is calcium is going to decrease and phosphorus is going to increase. There is a lot of different reasons why this happens. The kidneys are usually in control of producing and activating vitamin D. And vitamin D enhances the absorption of calcium through the gut. No vitamin D, no absorption of calcium, thus we have hypocalcemia. Now, the kidneys excrete potassium, nope, I said it again. Kidneys excrete phosphorus normally. Bad kidneys, no excretion of phosphorus. So here we have phosphorus retention. Now, phosphorus likes to bind with calcium. This is going to further decrease our calcium available for the body. It's very challenging. Not to mention when calcium begins dropping, the parathyroid hormone is going to be stimulated. And what happens to the bone under the influence of parathyroid hormone? Calcium is going to be released from the bone, and now we have bone density loss. That's going to lead us to something called renal osteodystrophy. We're going to look at that in a little bit, but it's a very challenging disorder because the bones will just get weaker and weaker as calcium tries to come out into the bloodstream. When calcium and phosphorus bond, we have a very crazy thing that happens inside the vessels. It's called calciphylaxis. Calciphylaxis, which is fancy for vascular calcification. So these calcium and phosphorus complexes deposit like atherosclerotic plaques on the intima of blood vessels. And I don't know if you know this, but vascular calcium deposits are a significant risk for cardiovascular disease because they also will begin clogging up our blood vessels and can't flow, and little plaques will be able to flick off and release somewhere into our bloodstream. Not good. This is a CT picture of vessels that have been calcified or are the result of calciphylaxis. As you can see here, they're actually highlighted in the CT where they should not be. Usually only bone is white. But how do you think the heart is going to do whenever it's pumping against very stiff calcified vessels? Do you think the person's going to have high blood pressure? Maybe yes, definitely. We are going to have more heart failure instances and more blood pressure management issues, and we're also going to have coronary artery issues. Now, our patients are going to struggle with hyperlipidemia. The fat metabolism is changed now, and the triglycerides, total cholesterol, and LDLs are going to naturally increase. Problems with atherosclerosis and lipids are significantly increased if our patient has that chronic kidney disease and diabetes. So you can imagine our patient's probably going to be on some kind of anti-lipid medication. Now, our patient is at risk for pericarditis. This is because the pericardial sac becomes inflamed from so much urea in the bloodstream, and possibly if our patient has an infection. But if we were to listen to our patient's chest, we may even hear a pericardial friction rub over the left sternal border. We're going to see that our patient is going to have anemia. This is because they're going to have their decreased erythropoietin levels caused by decreased red blood cell production. Now, uremia causes the red blood cell survival time to actually decrease, unfortunately. Not to mention that now we're going to have iron and folic acid deficiencies from a restricted diet. And looking at the GI system, the high urea causes uremic colitis. And uremic colitis can cause constipation or watery diarrhea. Ulcers will develop and erode through the blood vessels, which can lead to some severe GI bleeding, even to the point of hemorrhagic shock. I have definitely taken care of a few patients who have GI bleeds as a result of their chronic kidney disease. These are just some of the complications to review and the systems that it affects, chronic kidney disease affects. All right, here are our risk factors. What are the top 2 things? Hopefully you've noticed that I've bolded them and put them in color. Yes, diabetes and hypertension. Which of these things do you feel are maybe modifiable? Well, I hope we can modify some things, because patients who get 25% of patients who develop end-stage renal disease and go on hemodialysis actually die within their first year. So this is troublesome to know that so many things can hurt the kidneys, and oftentimes our things that we're doing to ourselves can be preventable. Do you see nephrotoxic medications there, such as NSAIDs? Who takes NSAIDs? Everyone. Well, particularly who takes them a lot. Maybe older people with arthritis, maybe greater than 60, yes. What's a huge contributor of arthritis? Obesity. How many people are obese? About 1/3 of America, right? So there are a couple of things here that we can do that are preventable. As you can see here, even at the bottom, obstructive uropathies. People of BPH, they're at risk for kidney disease, chronic kidney disease, and those who even have kidney stones. This is actually the short list too. Oh, here in the middle, systemic lupus. Yes, they may very well end up with chronic kidney disease. As we mentioned, chronic kidney disease is progressive, so our patient doesn't present usually in early kidney disease with all of these findings. Not possible, not going to happen. What is going to happen is very slowly over time, as their kidneys get worse and worse, we're going to see maybe 2 of these things, 3 of these things, 5, 6, 15. So to try to get a really good picture of what early kidney disease looks like nothing. What does late kidney disease look like? Probably some of these, not all, but you will definitely see somebody who is in end-stage kidney disease, maybe been on dialysis for a few years. They will most likely have all of these things. So let's list and point out a few. Neurologically, they are going to have this interesting pattern of neuropathy. They'll have a glove and stocking pattern of numbness over their hands and their feet. And what's nice is, well, not really nice. I shouldn't say nice at all. Another thing that we will notice is this encephalopathy, which means basically swelling in the brain. We are going to see that it resolves after somebody has hemodialysis. Moving on down into the cardiac section. Okay, on our cardiovascular manifestations, our patient's potassium is oftentimes going to be elevated, and so if we were to do an EKG on them, we're going to see tall peaked T waves. Tall peaked T waves. Oftentimes they are going to have fluid overload issues, so I'm going to sit them up, turn their head to the left, and look at their neck. What am I looking for? Hopefully you said jugular venous distension, or JVD. Very good. I can possibly listen to their heart, and if I do, I'm going to hear an S3 sound. That's what that blank is, S3. Here we go. They're going to have orthostatic hypotension, and this is because their vessels are so non-compliant because of the calciphylaxis that when they change positions, they will get dizzy oftentimes. We already mentioned the hyperlipidemia and the pericarditis and why that happens. In the respiratory system, oftentimes we will notice uremic halitosis, and that's fancy for their breath smells like urine. Yes. They will oftentimes have uremic lung, which has symptoms like pneumonia. They will have fever, tachypnea, pleural friction rub, and this is described as being like the sound of walking on fresh snow, or maybe leather on leather rubbing. That's what that sounds reminds me of. Kussmaul respirations, where are those going to come from? Maybe because our patient has metabolic acidosis. Right. What accompanies that? Yep, the high potassium, the lethargy, flaccid, twitchy legs. Hopefully our patient will not develop the frothy pink sputum, but this is a possibility for them to develop pulmonary edema. And on this one, the last one here, hematologic wise, our patient is going to be more anemic, and that's because they don't make erythropoietin any longer, so the bone is not stimulated to keep up with the body's demand for red blood cells. We'll see more cases of ecchymosis. The platelets are going to be a little bit more on the brittle side. Not that they're lower, but our patient does have more, say, brittle blood vessels, so whenever they break, they bruise oftentimes. And the melena is because of the GI bleed, which we'll see on the next slide, or because they often have GI bleeds. Okay. Urinary system. We're going to start noticing proteinuria if we were to grab a sample on our patient. We're going to see hematuria as well. Not because they have UTI, but because that's what happens when the kidneys begin failing. They don't reabsorb the blood like they're supposed to. The concentration is going to change. In early kidney disease, we're going to see polyuria. And in late kidney disease, we're going to see oliguria. Very good. Hopefully not anuria, but that is a possibility. The skin, we're going to have decreased skin turgor, and there's going to be a yellow cast to it if they are Caucasian race. In fact, right here is my example of somebody who has sallow skin. There's a little bit of that yellow cast, and the word for this right here is called, what we call this yellow cast skin, sallow. S-A-L-L-O-W, sallow. Their skin is also going to be dry, it's going to be itchy, and the reason it's itchy is because of the urea that is going to actually come through their pores, and when they sweat, it's very itchy and irritating. In fact, I don't know if you can even see this picture, but you're going to see little white crystals on our patient's skin. They call that uremic frost. So it may just to the common eye look like ashy skin and they needed some lotion, but it actually does have a little sparkle to it. All right, gastrointestinal wise, they're going to have ulcerations from the nose all the way down. We already talked about the melena, the uremic halitosis. They often have complaints of nausea and vomiting, and interestingly enough, metallic taste. In fact, they say that sweet foods are no longer sweet, and meats have a metallic or bitter taste to them. Skeletal-wise, our patients are going to be prone to have renal osteodystrophy. This is where the calcium is lost from the bones, and they're going to have thin, fragile bones. Anticipate some height loss, especially when osteodystrophy is advanced. Their skeletal muscles, such as their spine, is going to shorten. Okay. Skeletal-wise as well, notice some weight loss. This can be from the anorexia. Anorexia is pretty typical if someone has high urea levels. They just don't have any appetite anymore. You can also anticipate some weight gain. I know, it's such a yin yang, isn't it? This is because of the episodes of fluid retention. And reproductive, our patient is going to have a type of organic ED. It's not related to stress or anything, and so they're going to have erectile dysfunction. See if there's anything else I would like to say. Yeah, I think I'm pretty good. Some of these subjective manifestations, if you were to do a good interview on your client, is that they're going to complain of fatigue being the most common and profound problem. Fatigue right there. They will also complain of lethargy, those twitchy legs, that may or may not be the result of metabolic acidosis, but they do have like restless leg syndrome. Oddly enough, the high urea will have them develop hiccups, and this is because the urea is irritating to the diaphragm, so the patient will have hiccups. What are some laboratory tests that we're going to do for our patient? Well, we're going to grab a urinalysis, and as I mentioned, we're going to see the hematuria, we're going to see the protein. If our patient's a diabetic, we may even see glucose begin to spill into our urine. And depending upon the stage of kidney disease, we may see an increase in the specific gravity or a decrease, meaning it's more or less concentrated. Now, if we were to grab a urine osmolarity initially in our patients with early kidney disease, we're going to see it is going to be about, I was trying to think of a number. Well, I'll give you a number in a second. The urine osmolarity initially is going to be decreased. Then as the disease progresses, the urine osmolarity is going to be increased, and that's because it is more concentrated. And the norms for urine is about 280 to 300. Okay, moving down to our serum creatinine. Usually in chronic kidney disease, it's going to exceed 4, but it can get really high. Hopefully not. The big thing about serum creatinine in our patients with chronic kidney disease is ask what their baseline is. So if their baseline is 2, they will never be a 1.8. That is something that is sort of an average over time, so the goal is to go back to their baseline. Now, BUN, which is normally 10 to 20, could be as high as 180 to 200. And don't forget, this is the one where diet of protein-specific intake is going to be affected. Fluid balance also affects somebody's BUN. Okay, serum electrolytes, we're going to see that the sodium has changed as well as the calcium. It's going to go down. Now, what do you think the potassium, phosphorus, and mag is going to do? If you remember, we learned a little bit ago, it's going to go up. That's going to let us know that our kidneys are not doing so well. Okay, on our CBC, we're going to see that they have anemia, and possibly if they're less than 10 on their hemoglobin, we may need to do a transfusion. This is some different type of imaging that we can do to detect the disease process, maybe obstruction if possible, or if there's any arterial defects. Most of the time we're often just going to be looking at the blood work, but we can see its impact and influence on the rest of the body. We can do ultrasound of the kidneys to see if they are atrophied or maybe there's some kind of obstruction. We can also do a bone x-ray of the hands because this will show us somebody's, if they're developing renal osteodystrophy, you can actually see the gaps right there. There you go, the gaps right there. We will also probably do, oh goodness, there's a huge list here. I'll just point out a few. A CT scan without contrast. And why are we going to do it without contrast? That's because if we already have impaired kidney function, we want to make sure not to add that heavy ability or the heavy duty of filtering contrast. Right here, this is an arteriorenal angiogram. So they're actually able to see that there is some atherosclerosis and some kind of obstruction to the blood flow to the kidney. So there's a bunch of different methods we can do to try to detect why is a kidney not functioning. Is it something we can reverse and fix? This is an example of them doing a biopsy on kidney tissue. If you want to get official, this is actually a bone marrow biopsy, but I want you to just go with it because there's no way you would suck out that much of a biopsy on a kidney, but the picture's still the same. It really depends on the type of kidney failure they are suspecting and which test they are going to order. Okay, so let's focus on some interventions for patients who have early chronic kidney disease. First thing we need to do is encourage them to drink about 3 liters of water daily. We are going to consult with a provider regarding if there are restrictions or not. If they smoke, they definitely need to quit, so we're going to promote smoking cessation. We're going to encourage a diet and encourage good diet and activities that control or prevent diabetes and hypertension, because remember, those are the top 2 things. So focus on diabetes and hypertension prevention or control. If somebody, say, does have hypertension, we're going to place them on diuretics, calcium channel blockers, ACE inhibitors, alpha blockers, and we just learned about an alpha blocker in the previous urologic lecture. Does maybe tamsulosin or doxazosin come to mind? Right. Those can be very helpful in controlling high blood pressure. Beta blockers, vasodilators such as nitroglycerin. They do say that ACE inhibitors are the best way to help slow the progression of kidney disease, but there is a specific race that doesn't respond well to ACE inhibitors. Do you remember which that is? Right, Asians. Asians don't, no, I'm just kidding. African Americans. Sorry. African Americans don't respond as well, so what are we going to place them on? We're going to place them on calcium channel blockers. Good. Anytime we try to control their blood pressure and we add a new medication, we are going to initiate that drug and then we're going to reevaluate their creatinine to see if it's helping or hurting. In fact, if we see less than 25% creatinine increase, we're just going to continue the med and we're going to monitor it. If we see more than a 25% creatinine increase, we are going to stop our medication and we're going to evaluate, particularly that ACE inhibitor. It does have that Dr. Jekyll, Mr. Hyde kind of thing. Or is it Mr. Hyde, Dr. Jekyll? Makes you think there, doesn't it? All right. So let's see, adherence to medication administration. So we're going to encourage yearly testing for, what are you going to say? What do you think it is? Yearly testing for, I just can't wait. Do you know what it is? Okay, now I'm teasing. Yearly testing for albumin in the urine and serum BUN if the client, creatinine and BUN if the client has diabetes or hypertension. Let me say that all together. We're going to encourage yearly testing for albumin in the urine and serum creatinine and BUN if the client has diabetes or hypertension. Go to your yearly checkups. Let's see, when it comes to limiting over-the-counter NSAIDs, a patient is encouraged to use the lowest dose for the briefest period of time because this definitely interferes with the blood flow to the kidney. It slows it down a tad. So these are things we should focus on for patients who have early kidney disease. So now we're going to see our interventions begin to get a little bit more complex as the kidneys begin to fail. We're going to include all of the interventions on the previous slide except the one where we're asking you to tell patients to push fluids, roughly 3 liters per day. Fluid balance is now harder or going to get harder to manage because you don't want your patient to be too dry, but then they can't have too much fluid, because if they do, they're going to have fluid volume excess issues. So what's the best thing to do? Well, we're probably going to put them on a fluid restriction, which we're going to get to talk about that in just a second. But let's start daily weights with our patient. Daily weights. They are going to weigh themselves the same time each day, same scale, same clothes, which we recommend going in your birthday suit. That's right, your birthday suit. If they are to gain about 2 pounds overnight, or maybe 5 pounds in 1 week, they need to let the doctor know. This is going to guide the doctor in how they're going to prescribe medications for them, and if they need to have a fluid restriction or not. For their vital signs, our blood pressure may be on the high end or maybe on the lower end. So we're going to do some medication adjustments accordingly. You will probably see diuretics being ordered for your patient who has mild to moderate kidney disease. In fact, well, that was kind of the answer there. Mild to moderate kidney disease, you're going to use Lasix to excrete the extra fluids. I apologize. I didn't say that very clearly for you. Make sure our diuretics are not being used in severe or end-stage chronic renal failure. That is not preferred. That's because we can have the harmful effects of ototoxicity. Anytime we are doing diuretics in these patients, we want to make sure to avoid volume depletion. Avoid volume depletion. And how do you know if you volume depleted them? Well, what are our signs and symptoms of dehydration? Some common diuretics that we are going to use are, say, hydrochlorothiazide, spironolactone, and the osmotic one, that's, I wouldn't say it's common. I haven't given it very much, but mannitol. So let's continue to believe that our patient's chronic kidney disease has advanced to the fact where now they are on dialysis. And if that's the case where they're on dialysis now, we still are going to do daily weights on our patient. In fact, it's very important if they gain weight as say 2 pounds in 1 day, or if they have 3 pounds in between their hemodialysis sessions, that's definitely something to report. We are not going to give this patient any more diuretics. No more diuretics if you are in stage 4 or stage 5 kidney disease. And this is because we can have those complications of ototoxicity. We are going to put them on a fluid restriction. In fact, they will probably be consuming maybe 1 to 2 liters a day, and this really depends on their lab values and their actual output of urine, if they still make some. And then, last but not least, is the medication timing. It matters when you give them a medication if they're on dialysis, especially if it's their vitamins, sometimes they're antibiotics, and their anti-epileptic drugs. We want to make sure to give them after dialysis. If they are a morning dialysis, you're going to hold their drugs till the afternoon. If they're an afternoon dialysis patient, you can give them the medications in the early morning. So it's important to know when is that patient scheduled for dialysis, and then you'll give your medications accordingly. So these are some very broad interventions that you can apply to your patient, regardless if they are in early, mild, moderate, or severe end-stage renal disease. So we are first going to protect the client from injury. These patients are very brittle, they're fragile. Make sure not to lift them up by their limbs, which is what I have a picture of here. You want to use gait belts, and you want to use like lift sheets if you're pulling them up in bed. Do observe for unusual surface bumps or abnormal ranges of motion, because this may indicate that they have a broken bone. Regarding their medications, they probably should not take or have very limited use of NSAIDs, angiotensin converting enzyme inhibitors, And ARBs, I should just use the abbreviation, ACEs and ARBs should not be used together. They should not be used together. In fact, if we are going to do a study, maybe a diagnostic study, we are going to try to prefer that the patient not have IV contrast. Now, it's not an absolute contraindication, but it's good that they not do IV contrast, and if they do have to get it because we can't see what we need to see, then oftentimes we'll give our patient sodium bicarbonate. We will give them lots of fluids, and then we'll give them a medication which is the reversal for Tylenol, actually. It's called Mucomyst, acetylcysteine, and it's pretty gross. It smells like rotten eggs, actually, if you have to drink it. Okay, so some other medications we need to use very carefully are antifungals, because those can be nephrotoxic, some aminoglycosides, and some macrolides. Those can be nephrotoxic. Other medications we're going to use, I see a decrease in, is enoxaparin. You know that as Lovenox. They actually have a dosed amount for poor renal function, and that's going to be 30 milligrams. Typically, we're giving 40 milligrams, which is the syringe with the little yellow plunger, but instead now, if they have kidney disease, you're going to give 30, because if not, they are going to bleed a whole lot, because 40 is way too much for them. Also, some changes in medication. Patients should not have Maalox. Maalox has aluminum as well as magnesium, and this can put them at risk for hypermagnesemia. So they need to change their choice of laxatives if they are constipated. Also, medications such as digoxin will probably need an alteration in their dose, because a little bit goes a long way. So make sure you know things such as Dig's side effects. Okay, we're going to need to try to balance their energy levels because they suffer from fatigue, not to mention they're anemic. So what can we do with that? We're going to give them lots of periods of rest, try not to cluster activities, spread them out. We may want to administer epopoietin for the anemia, as well as get them iron tablets. And last but not least, provide emotional support. After a client's first year, they're going to start to feel the impact of their chronic condition because it just doesn't go away. In fact, there will probably be a loss of work, family roles, depression. All of this can contribute to non-adherence. So ask your patient, just ask them these questions. What does their self-care look like? Do they assist others with their ADLs? Do they feel refreshed from sleeping? Do they maintain contact with friends and family? Are they involved in self-help groups or religious groups for community support? If not, please encourage them to do all of those things so they can remain connected, grounded, and motivated to try to have the best life with their kidney disease. All right, general nutrition. Now this will be an exam question for the math part. So I'm going to ask you to remember the values that I'm about to give you, and then we're going to try to do some calculations. Okay, so protein intake is very important because which lab value was it that it elevates directly related to our protein intake? BUN, exactly. So our patients with kidney disease have to have changes in their protein intake. And it really depends on what stage of chronic kidney disease that they're in and if they're on dialysis or hemodialysis. Okay, enough. Get to the point. All right, so the first one here, let's see if I can even highlight it. Here we go. This one. They are supposed to have, folks who have chronic uremia, 0.55 to 0.6 grams per kilogram per day. That's 0.55 to 0.6 grams per kilogram of protein per day. This one right here should have 1 to 1.5. 1 to 1.5. They're allowed a little bit more because the kidney machine is doing all of the work of cleaning out the excessive urea in their blood. Now this right here, they are supposed to have a little bit more protein, 1.2 to 1.5, because some protein is lost in the peritoneal dialysis process. So theirs is 1.2 to 1.5. Our patient's general nutrition includes taking vitamins and minerals, definitely with iron for their anemia. We are going to continuously measure somebody's albumin and pre-albumin levels. Those are really good indicators of somebody's nutrition status, especially the pre-albumin. We have found out that protein restriction early in the disease prevents problems and preserves kidney function for longer. So make sure we get our patient to comply with this dietary restriction. In fact, why don't you go ahead and bring in a dietitian, because if a patient becomes malnourished and there's not enough protein, muscle wasting can develop, and this will put our patient in a really big compromised state. Let's talk about some specific interventions that we're going to do, all related to their lab values. So we're going to probably start them on lipid lowering therapy, and this is so they can't make those calcium phosphorus complexes. They don't have that chance with a low cholesterol to form. So check their lipid level and go from there.
Match the ice cream that you can.
According to a patient's vitamin D level, we may place them on vitamin D supplements. Remember, vitamin D helps to increase dietary calcium intake. Those vitamin D drugs are also known as cholecalciferol, or we can use calcitriol. Those both are vitamin D. We may need to administer the erythrocyte stimulating agent, such as apopoetin. Once again, if their hemoglobin is less than 10. Do make sure that they have adequate iron stores, so let's grab an iron level as well. Otherwise, our drug will not be very effective. We can administer sodium bicarbonate tablets, and this will help correct any metabolic acidosis, and it even has been shown to slow progression of the disease and improve patient functional status. We're going to restrict our patient's dietary intake of sodium, potassium, phosphorus, and magnesium, all depending upon what their labs show. In general, though, we are going to place them on a 2 gram of sodium diet limit per day. They are not allowed to use table salt. In fact, they need to be very careful when they use salt substitutes, because if you look at the ingredients for a salt substitute, you will read it is potassium chloride. It does not taste good, just trust me. Their best bet is to use things like rosemary, lemon, other herbs to try to add flavor to things. They're going to have to use dietary phosphate restriction. Oftentimes we will have patients take phosphate binders. I have some examples of phosphate binders that include Foslo, Caltrate, Renagel. These are not over-the-counter items. This is something that is prescribed and they take with every meal and snack. So if a patient is NPO, you're supposed to hold those medications. We are possibly going to reduce a patient's potassium intake. What's really interesting is that if a patient is on peritoneal dialysis, they actually have no potassium restriction. That is a cool thing. I actually have a couple of pictures on the next slides to show you what food has potassium in it. These are foods that should be avoided. I'm going to let you pause the slide if you want to look at everything, but I'm moving forward. These are foods that have low potassium, and we are trying to encourage our patient to eat these foods. Medications. Now, we probably already know by now, if I haven't already said it, patients need a reduced amount of their medications, particularly if they are renally cleared. If our patient is diabetic, we are going to try to keep their hemoglobin A1C to about a 7. Now, what is that again, that hemoglobin A1C? You may have to go back to your renal lecture, but a hemoglobin A1C is a good way to measure if somebody's average blood sugar is been low or high or in control or out of control over like a 3-month time frame. The normals again are about 4 to 6%. We know that a person is diagnosed as diabetic if they are greater than 6.5. However, because our patients with diabetes and kidney disease can become brittle diabetics, meaning they yin-yang on their blood sugar, so we want them at about a 7%. Sometimes the doctors will go a little bit higher than 7%, and that's if he or she feels that our patient is at greater risk for hypoglycemia. So they'll let them have like a 7.2 or 7.4. But do remember that greater than 8% is a poor control of diabetes, or means they have a poor control of diabetes. So what does this mean? That blank right there, reduce your anti-diabetic medications. So your insulin doses are going to be lower, your Lantus doses are going to be lower, all doses of diabetic meds are going to be lower. Opioids and antibiotics. Let's see, is it recording? Yeah, okay. Opioids and antibiotics are actually going to last a lot longer in the system too, so please make sure to remember to give your person a reduced dose of opioids, otherwise you will very quickly overdose your patients. There are medications that promote hyperkalemia. Those medications include ACE inhibitors, ARBs, potassium-sparing diuretics, and COX-2 inhibitors such as Celebrex or Celecoxib that our patients with arthritis like to take. And NSAIDs as well. Those all promote hyperkalemia states. So if, let's just say, our hyperkalemia needs to be controlled, there is a medication that we can use. It's called K-Exalate. It's called K-Exalate. This is a fantastic drug we can give patients to lower their potassium, but I do warn you, it lowers their potassium by giving your patient diarrhea. So you know our patient's going to be prone to pulmonary edema, specifically fluid volume excess. Well, how are we going to take care of this patient? Well, you know which side of the heart had to fail to lead to pulmonary edema? Was it the left side of the heart or the right side? You are correct if you said the left side. Early signs and symptoms of left-sided heart failure and pulmonary edema include restlessness, anxiety, tachycardia, shortness of breath, crackles that may even increase up the lung, as well as late signs and symptoms of pulmonary edema, which include pink frothy sputum, diaphoresis, and cyanosis, which is what I have pictures of here. We want to administer our patient oxygen. We like to think that we start at the lowest dose, but occasionally you may have to put a mask on a patient depending upon how bad their saturation is. We want to give them Lasix IV if they are in mild to early kidney stage, mild to moderate chronic kidney disease, you can give them Lasix IV. Diuresis will begin in about 5 minutes in most patients. Now, if they are end-stage renal disease, like stage 4 or stage 5, they need emergent dialysis. Lasix is not going to do anything for them. That blank right there, we can give them nitroglycerin. This is going to reduce their preload, so make sure to give your patient some nitroglycerin right there. We can also administer some morphine. This is going to reduce their heart's demand for oxygen, but please make sure to watch for hypotension if you are giving them nitro at the same time. There is a chance that you are going to have to intubate your patient and mechanically ventilate them, especially if respiratory failure occurs. Well, how do I know if respiratory failure has actually happened? Well, good question. This is if their stats declined and you can't bring them up, there's a loss of consciousness, their blood gases are worse, and if they are so fatigued that their breaths are now ineffective. It's time to intubate them. You have completed the lecture on kidney disease, and let's do a few post-lecture questions to see if you remember anything. Okay, please pause. I'm going to advance forward. This is your answer. Pause again if you want to read the rationales. Question number 2. Please pause the slide. Pause the slide again. Pause. Unpause. Here is your answer. I believe I have one. No, I have a few more questions. I think 2. You're almost to the end. Please pause. Sorry, you were hoping for an answer from me. In fact, if you need the rationale, I have put it in the notes section here, but here the patient is exhibiting symptoms of pericarditis, which can occur with chronic kidney disease. Continuity of care is important to assess for these subtle changes in patients. Therefore, the registered nurse who is assigned to this patient previously would give the best care to this patient. The float nurse may not be as knowledgeable about the unit and its patients. The LPN nurse may not have the educational level of the RN to assess for pericarditis. Last question. Pause. And there's your answer. There are some medications that are nephrotoxic such as NSAIDs, such as ibuprofen, aspirin, naproxen. This would be good to question your person initially to ask if they've had a rise in creatinine and BUN, because that does indicate some renal problems. Just asking about a history of renal failure and kidney transplant would not be part of the questioning and could cause anxiety in the patient. And a diet high in protein could be a factor in increased BUN, but not so much the creatinine too. We have reached the end. I am out of coffee. I know you are too. Have a wonderful day. And if you need to re-listen to it, I'll encourage you to do so. But bye for now.